So most of you know me. I'm Shuba Barwick. I'm one of the paediatric cardiologists at Leeds, and I'm the lead for fetal cardiology. And Jan's told you a little bit about our service today. And I know Jan's already covered this, but I wanted to reiterate the importance of antenatal diagnosis of congenital heart disease. It allows a time for the families to understand the diagnosis, prepare themselves, prepare the siblings of the child, but also for considerations of the management of the pregnancy. The Leeds data, which is quite similar to the rest of the country, suggests that up to 50% of pregnancies are terminated when there is a single ventricle diagnosis made in the mid-trimester screening. Antenatally diagnosing congenital heart disease also allows us to plan the place of delivery. So making sure that the appropriate expertise is available. It doesn't always mean delivery in Leeds, and we have developed some place of delivery guidelines, which I won't go into because I know Lawrence is talking about that later. And this is all about improving outcome and also managing the families and parental expectation. Knowing about these problems allows us to work very closely with fetal medicine, neonates, and the regional obstetric departments. And we have a weekly MDT where we discuss cases all across the region. And as mentioned already, the hospice can be involved if there is a very complex diagnosis and the family choose not to intervene. Just wanted to give you a very quick background about improved outcomes. There isn't a lot of clear evidence about improved outcomes sorry, my doorbell's just going, so I'm just going to ignore that. There isn't a huge amount of evidence on when a diagnosis of congenital heart disease is made, but transposition of the great arteries, and you'll hear us all talk about the importance of delivering in Leeds, and it's one of the diagnoses where there is clear evidence. The data from France suggested that 12% of an antenatal group needed urgent septostomy in the delivery room. We've done a recent study which showed that 18% were diagnosed antenatally as having a restrictive atrial septum, but actually 82% had a septostomy within the first 48 hours after delivery. So it goes to show it's really important to have them on site where paediatric cardiologists are available, and again, reducing separation of the mum and baby. So this is a blanket sort of advocation of delivering transpositions in-house, and we're super lucky. I think we're at one of only 2 centres in the country where we're truly co-located with fetal medicine, obstetrics, neonates, paediatric cardiology, paediatric cardiac intensive care are all on one site. So in hypoplastic left heart syndrome, there was improved hospital survival in the antenatal group. These are all old papers. There isn't a huge amount of data out there, and there isn't much up-to-date data. They found fewer adverse perioperative neurological events, but there wasn't an impact on the post-operative survival. And again, there's a very small study looking at coarctation of the aorta saying that you're much more likely to collapse or die if you're not diagnosed antenatally, which is obviously a clear endpoint. So I've been asked to talk today about the National Congenital Heart Disease Audit, or the NCHDA. So this was set up in 2000, and prior to that, it was known as the CCAD, or the Central Cardiac Audit Database. And John Gibbs, who was one of the cardiology consultants here in Leeds, was instrumental in setting that up. And the aim is to collect data all across the board and assess outcomes after intervention, so cardiac surgery, intervention, and electrophysiology. And it is the largest comprehensive national audit in the world. And the reason it works is because data submission is mandatory, and all centres who undertake procedures have to submit their data. So each financial year, a report is published, and it looks at the 30-day mortality for procedures, and they have a list of procedures, the numbers of procedures, and also the numbers of antenatal diagnoses. So the most recent report is the 2021 report. So that has 3 blocks of data. So you've got your most recent full financial year, so the 2019 to 2020 data, and then they look at a 3-year block and also extrapolate back a 10-year block to look at trends. So I'm going to talk about the antenatal diagnosis of congenital heart disease and what data is collected. So what they're saying is that 20 to 30% of congenital heart defects are severe and life-threatening and require surgery within the first year of life. The difficulty is that the NCHD data only collects data for those undergoing surgery within the first year of life. So I feel quite strongly that this isn't a true representation, because you don't know about intrauterine death, you don't know about termination, those that are born but are not able to be treated. So the denominator, I don't think is true, or the numerator for that matter. And they look at the antenatal detection against procedures with a prenatal diagnosis. So these are interventions within the first year of life. The other limitation is that only 4 diagnoses are looked at, and Janet mentioned this in the FASP screening protocols. So these are the only 4 reportable lesions. They are important reportable lesions, but there are only 4. So hypoplastic left heart syndrome, which again is a major abnormality, a clear abnormality that's seen on an abnormal 4-chamber view. Transposition of the great arteries is a much more difficult diagnosis to make, but it is one where it is vital to make that diagnosis, as I've mentioned already. Tetralogy of Fallot and a complete AVSD, and Jan showed a beautiful image there of a complete AVSD and how abnormal it can look. So there aren't any agreed international standards about how much we should be detecting. Early in the 2000s, there's data published by the Paris team that in the whole of the Paris sort of area, their detection rate of antenatal detection rates were 80%. And this is when it was 30-40% in the UK. And education is the only way to improve that. So the National Fetal Cardiology Working Group, of which I'm a member, have made a recommendation that we should try and achieve a 75% diagnosis for all abnormalities where intervention is undertaken in the first year of life. So that's saying the most important diagnoses. That's excluding VSDs, PDAs, things that aren't hemodynamically that significant within the first year, and specifically those that need intervention within the first few hours. So your transpositions, that we should be diagnosing at least 75% of them, and that seems really quite sensible. I've talked about this a bit already, so it doesn't cover the majority of what we actually see in utero. And only the diagnosis is submitted. And fetal cardiology is quite a different spectrum to postnatal cardiology, because the coexistence of other abnormalities, chromosomal abnormalities, extracardiac abnormalities, all have a huge bearing on the outcome of the congenital heart disease. So actually, a hypoplast with an absent lung is going to do much worse than a straightforward hypoplast, for example. And so this is really, really important. And the Fetal Cardiology Working Group are pushing to have more diagnoses included, and also to collect further information on terminations, intrauterine death, those who have a postnatal death where there is an intention to treat, and the extracardiac stuff as well. So Jan's shown a similar diagram to this, and what this shows is that from the in the sort of 10-year period, we've gone from an overall approximately 30% diagnosis to 50% diagnosis. 50% is still relatively low. When you think about intervention immediately after birth. But as Jan did show before, the diagnosis has always been pretty good for something really quite major, such as hypoplastic left heart syndrome, and is now up there at sort of 90%-ish. The transposition, importantly, the diagnosis has improved, and that's really important because of making a difference. So overall, there are continuing positive trends, which is a very important move forward. And looking at the regional antenatal detection rate, I'm not going to go into this too much because that's the remit of Layla's talk afterwards. So it's a bit difficult to see, but we're Q50, Q51 and Q52. That covers the whole of our patch, which is North Yorkshire, South Yorkshire and West Yorkshire. And what I'm pleased to say is, if you could, I'll just move on to the next one. I've tried to highlight them with red arrows. And if this is the sort of the 50% line, and that's what we're saying that the national average is, all our dots are either on the line or above them. So that is good. And I thought it was a bit clearer to see it in this diagram. So this is the overall diagnosis in the 2000 to 17 to 20 era on the left. For some reason, my mouse has decided to completely disappear. And you know, this is our patch here. So we were in the kind of the reasonable categories, but not the best areas. But it's really good to see that we've kind of certainly improved our detection rate in the more recent time period. So just to reiterate again, so it's really important for families to be able to understand the diagnosis, make decisions, plan the place of delivery, and also for us to all work together as an MDT. It's a bit of a whistle-stop